Hello, welcome to case-based learning of cardiac MRI on mricardiac.com. Middle-aged male presented with recent history of myocardial infarction. The MRI scan was done on day 2 post-MI. These are cine short axis TAC images, and as we see over here, anterior and anteroseptal segments reveal akinesia. There is no systolic thickening over here. Since it is acute infarction, there is no significant myocardial thinning, but this area definitely looks abnormal. First pass perfusion images, it reveals extensive perfusion defect in the basal, anteroseptal, mid-anterior and anteroseptal, apical septal, and apical inferior segments. These are the late gadolinium enhancement images. As you compare with the cine and LG images, there is a large area of microvascular obstruction within this anterior and anteroseptal segments in LAD territory. Same area which reveals akinesia and no systolic thickening presents as a large hypointensity on LG images. This represents microvascular obstruction. Note this delayed enhancement at the periphery. So within this infarcted core, there is this large area of MVO or no reflow phenomenon which is seen. Same thing is seen on the long axis images as you see over here. No wall motion, but there is extensive hypointensity representing microvascular obstruction. Again, these are the LG images. Note the presence of scar and microvascular obstruction within the scar, within the infarct core. So to understand microvascular obstruction, first let us understand pathophysiology of acute myocardial ischemia. Acute myocardial infarction develops when myocardial ischemia lasts for more than 20 to 40 minutes. It starts mainly in the subendocardial area because that is the least perfused area, after which it spreads as wavefront to the epicardial layer with increasing duration. So whenever there is prolonged ischemia, increasing duration of ischemia, initially after 20 to 40 minutes, it starts from the subendocardial and later on it progresses for a transmural infarct. Complete transmural necrosis at least takes around when ischemia lasts for 4 to 6 hours. In case if the ischemic myocardium is perfused early, degree of myocardial salvage can exceed necrosis. However, there is one other component to it which is related to microvascular obstruction and intramyocardial hemorrhage. That basically occurs because of the reperfusion injury. Reperfusion related expansion or worsening of ischemic cardiac injury results in MVO. Basically, whenever there is acute myocardial infarction, there is some part of inflammation which leads to edema in the myocardium. There is also the endothelial dysfunction. And because of reperfusion, whether it is natural or whether it is iatrogenic, it leads to endothelial dysfunction, some distal embolization, and microvascular thrombosis. All these are the features of reperfusion injury. Initially, it can lead to stunning of myocardium and occasionally arrhythmia. Microvascular obstruction or no reflow, which would be seen at the infarct site as a no reflow phenomenon. Later on, it leads to myocyte death and some part of the hemorrhage also occurs within necrosis. So as you see over here, microvascular obstruction and intramyocardial hemorrhage, basically they are progressive pathology of reperfusion injury. They are closely linked and often coexist. So basically microvascular obstruction represents damage and dysfunction of myocardial vasculature with no reflow phenomenon. And it is seen within the infarct core. It arises following reperfusion therapy in patients with prolonged ischemia. So whenever the ischemia lasts for longer time and reperfusion happens either naturally or iatrogenically, there are high chances that MVO happens. The different pathologic mechanisms which are thought about the formation of MBO is prolonged ischemic injury or reperfusion, rarely distal embolization, and when the microcirculation gets damaged. However, whatever it is, when it occurs, it is associated with adverse LV remodeling and poor prognosis. Therefore, the accurate detection is crucial. MVO extent is an independent predictor of all-cause mortality and heart failure. So detection of MVO is crucial importance in acute myocardial infarction. So this is how the infarct looks like. This is the remote myocardium, and here is the blood pool. This represents the area of myocardial edema or area at risk, while this part, which would be less perfused, will represent an infarct. Within the infarct core, this dark area may represent microvascular obstruction, and within this microvascular obstruction, you may get a thin linear stripe of intramyocardial hemorrhage. To evaluate MVO, you may able to see on first pass perfusion, as we had seen in our case. Occasionally, early gadolinium enhancement images are preferred. Basically, these are obtained after 2 to 3 minutes of contrast administration, and these are performed with high TI, that is 440 ms TI values. MVOs can also be seen on LG images at 10 minutes of interval. However, MVO will gradually resolve, but the myocardial scar will persist. So it is important to understand the temporal evaluation of MVO. However, as we have seen earlier, intramyocardial hemorrhage is a subset of severe microvascular damage that is usually associated with MVO. It is basically destruction of the vascular endothelium and with leakage of erythrocytes from microvasculature into surrounding tissues. Presence of intramyocardial hemorrhage is a malicious sign, and severe ischemic injury along with reperfusion results in microvascular damage. This damage can raise from MVO, which can further progress to IMH. In the healing phase, necrotic tissue is replaced by scar. To understand the temporal evaluation, it is important that MVO increases threefold during first 48 hours of infarction. So you will see extensive MVO immediately in acute phases. However, scanning early, that is within few hours, will result in underestimate. So it is ideally better that to evaluate MVO, we assess within around after 48 hours. After that period, again MVO will decrease between the first and second month on follow-up. Early enhancement, as you see over here, which is obtained at 3-4 minutes of interval post-contrast, that can depict higher MVO as compared to 10 minutes interval. However, most of the studies which have documented and they have done the analysis have calculated MVO on the 10 minutes images. So LG images of 10 images, 10 minutes are preferred for the early MVO depiction because it is considered as a one of the important parameter for negative remodeling. Parametric mapping, mainly T2 star, can detect hemoglobin breakdown products, and this allows pixel-wise determination of the iron deposits. So this can be used for the detection of intramyocardial hemorrhage, while T2 mapping can be used for edema and evaluation of the area at risk. However, all these studies need additional validation, and there are no definite parameters which are available as of now. Thank you. Similar concepts can be found on our textbook, Cardiac MRI Simplified. Stay tuned for more similar cases. And for any feedback or suggestions, please mail us to info@mricardiac.com. Thank you.